Hello and thanks for joining us on The Wonk, where we take a look at the urgent issues facing New Yorkers and dive into politics and policy to find solutions. I'm your host, Michael Jacobson, director of the CUNY Institute for State and Local Governance. On today's show, inequality in health and healthcare. Health is fundamental to daily life, but lack of access and many other disparities are issues for everyone, especially vulnerable populations. Alongside our studio guests, we'll explore this subject and how we may need to expand how we think about healthcare in order to improve it. But first, CUNY TV correspondent Andrew Falzone looks at Medicaid and the immediate needs process in New York State.
Perhaps no other element of the American healthcare system better exemplifies its inequality than the bureaucracy surrounding Medicaid. The system that's designed to help the poor and disabled is so complicated, it often requires a lawyer to properly fill out the 15-page application. Medicaid's a federally funded program managed by the states and administered at the county level. Among the services provided by Medicaid are in-home aides to provide personal care assistance to those who need it. But getting home care approved used to take months. However, in the past year, New York State has rolled out a new process called Immediate Needs with the goal of getting people the home care they need as quickly as possible.
If anyone has an immediate need, it's someone who's just been hospitalized or someone who's just been in rehab after being hospitalized. I mean, these are urgent sort of situations where someone's, even more in need of care. But yet you wouldn't be eligible for this if it was just like a temporary, if you just broke your leg.
But the immediate need process can be used by those who have chronic long-term conditions like dementia, ALS, Parkinson's, or Alzheimer's. Valerie Bogart is the director of the Evelyn Frank Resource Center at the New York Legal Assistance Group, or NYLAG. She says the immediate needs process is a much-needed improvement in the state's healthcare process.
The benefits of this process cannot be overstated. It really allows people to obtain Medicaid and home care quickly, relatively quickly.
Under the state guidelines, someone who requires immediate home care can get their Medicaid application approved in 7 days and their home care services approved in 12. And while it may take a little longer than 12 days if there are complications, it's still better than the old process.
Even by law, the local Medicaid offices that are run by counties or in New York City by the Human Resources Administration have 45 days to do those applications. And then after that, it can be another month, 2, 3, even 4 months to then enroll in a managed long-term care plan, which is the entity by which the state has now delegated providing home care.
And for many patients, it's true, there really is no place like home.
Many people really revive. I mean, you don't cure dementia, you don't cure a stroke, but their mental attitude, depression sometimes lifts, and they even do regain some physical function, some interest in eating, abilities, and they want to be home, which is where most people want to age.
While it may be advisable to consult a Medicaid attorney to complete a Medicaid application, the rest of the immediate needs process can likely be handled by a diligent patient advocate like a close friend or family member. If you find yourself requiring help, you can find the contact information for NYLAG on their website at nylag.org. I'm Andrew Falzone for The Wonk on CUNY TV.
Today we are speaking with 3 guests. Here with me are Dr. Ayman Elmohandes, Dean of the CUNY School of Public Health and Health Policy, Dr. Lilian Barrios Paoli, Special Advisor to the President at Hunter College and former Deputy Mayor for Health and Human Services, and Dr. Victoria Lawson, Senior Research Associate at the Institute for State and Local Governance. Welcome, everyone. So let me start with you, Victoria, since you manage the inequality work that the State and Local Governance Institute does. One of the areas you look at is healthcare. So why don't you provide us some initial context for what you've found, some of the big findings, and then we'll work off of that.
In New York City, we look at economy, education, health, housing, justice, and services. And we've been doing this now for 3 years. We have 3 years of data, and health is consistently the worst out of all of the domains. It's actually, it had the most improvement this year from the baseline, and it still did the worst sort of out of anywhere. A lot of that seems to be really low scores in things like quality of healthcare and in mortality. And just as an example, in quality of healthcare, we look at things like preventable hospitalizations. There, blacks are 5 times more likely than whites to be hospitalized for asthma. So we're talking about some really big, significant differences here. And one of the interesting things to us, at least, is that we know there are these huge disparities, and yet there seems to be a disconnect between the data itself and what the public sees. So every year, as part of data collection, we do a public survey. And one of the things we ask people is, what's the biggest inequality issue facing New York right now? And no one says health. No one mentions it. It doesn't come up. So clearly, this is a huge disparity, a huge inequality problem, but people just don't see it that way. And that's something that's been really interesting to us.
Yeah, that's fascinating. And so let me throw it over to you, Ayman, because you're the dean of the School of Public Health, but you're also a national and global expert. How do you make sense of that, especially that last issue, the sort of glaring disparities that we find in healthcare, and yet when we talk to the public, that's a subject that they rarely mention in terms of disparities? How do we put those two things together?
We recognize today that the living environment, the work environment, the family unit, the community within which people live, the availability of healthy foods, transportation, all of these factors are essential and impact health in a very direct way. This kind of awareness needs to be disseminated widely and needs to be emphasized to the public so that when they're looking out for their own health, they take into consideration factors that are known now to impact health. And our ability to express to the public, increase their awareness, and increase their vigilance in trying to understand not just their own personal health as a priority, but also the health of their families, their extended networks, and their community are essential components of their own health. And obviously, there's a lot of work to be done.
A perfect segue to Lilium in terms of the work to be done, right? You've run these systems for New York City as the deputy mayor. You were the chair of the city's Health and Hospital Corporation. You've sort of lived in this world. How do you begin to address these sort of huge, complicated issues that Ayman was talking about, especially in getting people to perceive healthcare in a different way than they do now?
Yeah, I think that most people think of healthcare as sick care. So I'm sick, I go to the hospital, and I have access in their mind. And they don't think of it as well care. They don't think that an essential part of health is prevention. An essential part of health is understanding how things impact on you. You know, asthma is a perfect example. If you realize how important the environment is, how important triggers are, then you can start planning and you can avoid being in a hospital. So I think part of it is a lot of education. So people understand that health is not just, I'm sick, I go to the hospital, but it's a lot that goes into it. But also the awareness, how, you know, housing has a tremendous impact, the neighborhood has a tremendous impact, your diet has a huge impact, and people don't think of it that way.
And so let me just follow up with you or any of you. So how do you get people to think of it that way? Is this just a simple, not simple, but a public education campaign?
Yeah, I think involving communities as well and starting at the grassroots level with participation. You raise awareness amongst opinion leaders in communities, and you begin to make them aware of the variables, the factors within a community. Living in a healthy community, raising awareness of the health indicators within your own community and participation from the community in change are very, very essential. Some of the issues that have been discussed and talked about a lot are things like exercise. You know, we are advising people who are overweight to go out and have walks in their communities, and it's been said 100 times that if the community is not safe, who's going to go out and have a walk after work? And if the kind of job that you have is so tedious, then you're less likely to have any energy for healthy exercise. Furthermore, the issue of mental health and how it impacts on people's participation in nothing else but prioritizing their own health.
Let me follow it up with you because I mean, you're not only an expert on this sort of local and nationally, but you have a very good global perspective. I mean, are there sort of examples of best practice here? I mean, not just in who does healthcare better than us, although that's part of it, but you know, what can we learn from whether it's other countries, other parts of the globe, other cities that have sort of made strides, at least in getting people to sort of think about healthcare differently and have more community participation in these issues than we do now?
Yeah, I'll give you an example of what's called community-oriented primary care, a terminology that has been used widely and globally, COPC. And community-oriented primary care is a situation where the primary care health system enters into partnership with communities, shares information with the communities, comes up with a list of priorities for where the communities see their health problems are, responds to that with their collaboration and to their satisfaction, where the community feels empowered that it can in fact change its own health profile. Sharing information is very, very important, and sharing information in the simplest way and the most digestible way is key to involving communities in change. Sharing information, what we call today population informatics, is sharing data in a simple way, allowing people to gather data about themselves, collect it, think about it, and begin to participate in the change. The problems sometimes are many, and that is daunting, because the riskier communities have a lot of problems. You know, and I know that from practice. And so sometimes starting with one problem and reaching a point where the community feels empowered that it has been able to sustain an intervention that brought about a change gives them a sense that they can make even bigger things happen.
Right.
Ill health sucks away the energy from communities, and communities that are healthier are more vibrant and more capable of change. So you have to start with smaller attainable things, and you cannot get into the community and tell them, this is your big health problem. You may be entering into a small village in Africa and you know that HIV and tuberculosis is burning this community up. But when you go to the community itself and ask them what their health problem is, maybe they'll come up with something like stray dogs. And you suddenly feel like, what do I know about stray dogs? And so you begin to learn, and you begin to respond, and you begin to react, and you begin to collaborate, and you begin to make small changes.
What you just said, Ayman, makes complete sense to me, but from a practitioner point of view, right, as someone who sort of works and makes policy on the ground, how do you do that? What is to be done?
So I'll give you an example. When I was Commissioner of Aging, we realized that there was a lot of chronic issues, diabetes, high blood pressure, heart disease among the seniors, and a lot of it was tied to lack of exercise, bad diet, many of them depression. So we started doing interventions in senior centers with many of them with peers, just having circles of conversation around what is diabetes, how do you monitor it, what do you eat, what can help. And we saw the numbers really change because the seniors took control of their own life and they monitored each other, which was even better. So you can do that. You can really do that. We're doing that now in a school in East Harlem, where we're really trying to talk to the kids about nutrition, about what they eat, how can they eat differently. You can make inroads by dealing at the very local level in very small interventions that begin to amount, as you say. They begin to really bank on each other. Right.
So I want to turn to Victoria for a second, because I want to get a little more granular here and talk about this issue with healthcare, and especially disparities and immigrants, both lawful and undocumented. So, but before I do, maybe you can just, again, give us a little bit of context about what the research says, what you found about the relationship between healthcare and immigration status, and then I want to follow up on some of those issues with you folks.
Yeah, I mean, obviously it's a very tricky issue, and there are many different barriers to care at this point. Some of them vary by the state, some of them are sort of federal level things. And what that results in is a lot of people using emergency departments as primary care, or being afraid to even go to emergency departments at this point, which obviously compounds existing problems and ends up creating much bigger disparities. But even for people who are lawfully present, there are huge disparities that we see in terms of going to a doctor, in terms of getting medical care. It's a huge issue that's facing us right now. And I think the fact that there's so much uncertainty about what's happening with the safety net, with Medicaid, with so many other things, is only going to make that worse for the time being.
One of the reasons I want to talk about immigrants and immigration status specifically is it's obviously one of our vulnerable populations that we look at, but also in the current sort of toxic and political environment about immigrants and immigration, healthcare is, whether you recognize it or not, a sort of big part of this issue. And so one would imagine, that in the midst of this debate, the 11 million or so undocumented folks who live here, who are now have to be experiencing higher levels of stress, uncertainty, maybe even trauma, this has to be a healthcare issue, not just an immigration policy issue.
Actually, pure and simple, it's also an economic issue. I mean, if we are approaching this from a very pragmatic point of view, an undocumented pregnant woman living in New York City today that has a preventable condition but cannot receive prenatal care because she has no coverage will then deliver a baby with a health problem that's going to go to an intensive care unit and cost the taxpayer upward of $500,000. The prenatal care that she would have received would not by any standard have cost more than a few thousand. So even if we're thinking in a very pragmatic way, having somebody who is an undocumented immigrant, who has diabetes, who because the diabetes is not managed well, suffers a heart attack or a stroke, will be admitted to the emergency room, will be admitted to the intensive care unit, and will cost us upward of $1 million. Even if we're heartless, even if we don't care, even if we don't care what happens to that fellow human being, let us at least think from a purely pragmatic perspective, and let us understand that not providing care to healthy or sick people has consequences that affect all of us.
It is so interesting that sort of the disparity between the sort of toxicity of the current debate and the sort of substance that you're talking about, and you've obviously experienced this on the ground.
Totally. I mean, in the municipal hospitals, which are, the place of last resort for most undocumented and undocumented immigrants that have no coverage, you see that all the time. I mean, they come in with things in the emergency room that could have been prevented, but, now you have to deal with them. I mean, I think there are also other barriers that people have. They don't take care of their health immediately in primary care settings because of money. They don't make enough. They sometimes they're paid below minimum salary, so that's a real barrier. There are cultural barriers. You don't go to the doctor unless you really, really, really are sick. You don't think of preventing things. So I think that there are a number of barriers to begin with, but I think it's the sense that they're afraid. I mean, you do now have fear. People are very afraid of doing anything that can flag them to anyone, in authority that could potentially get them deported. Right. And it's very scary. In New York, it's better than in other places because you don't ask, if you go to an emergency room, you don't ask anyone for their immigration status. But in other places, it's very scary. You have to really want to take a risk to go someplace.
Yeah. You have to be really sick by the time you do it.
Absolutely, because you're taking, you might very well be arrested and deported.
The federal sort of tax reform, such as it is, one of the things it did was repeal the individual mandate. So there are all sorts of estimates for how many fewer people will have health care, but whatever that number is, it probably is going to fall on these vulnerable groups. But what impact does that have for a system like the health and hospital system? in New York City, which is sort of geared to help these groups. What does it mean for not just the system for healthcare, but for the city, for some large numbers now, you would think, who are now not going to have health coverage?
Right. I mean, I think people make decisions for the moment. You know, right now I'm healthy and I can't afford to pay for this, and so therefore I'm not going to have coverage. And I think what happens, you know, if you look at the payer mix of health and hospitals, it's a very problematic thing. You know, there's a very large number of people who are uninsured. I mean, it's 30 to 40% in some of the hospitals, and then you have, you know, people who are Medicaid insured. And very few, very few people have third-party payers that are not Medicaid, Medicare, or uninsured. So, you know, getting the hospitals to really be self-supporting it's almost an impossibility given the situation with the insurance in the insurance world for healthcare. So it's very, very problematic. And they don't, you know, you don't turn anybody away. You shouldn't and you can't, right?
Right.
So, and not only that, in other emergency rooms of other hospitals, once you've already exhausted your emergency Medicaid, then you get promptly taken to one of the municipal hospitals. So it's a very problematic thing.
Yeah. But prior to the expansion of Medicaid, HHC in New York City had a very favorable system where undocumenteds could present for health care, and based on their self-declared income would be offered a self-pay equivalent to their ability to pay. So HHC has a history of providing a safety net in a way that is truly enviable by most cities' standards.
Correct.
And you know, this system, if worse comes to worst, and if the Medicaid coverage is pulled from underneath our feet, we will go back to the socially responsible New York City systems that pre-existed Medicaid. At the present moment, I agree with Lillian. Even if you're Medicaid covered, and if you feel like you're living in an environment, if you presented yourself to healthcare and risked deportation, you'd think 3 times. Coverage is not the only issue today.
Right.
Right.
And so it's really a very difficult situation that we are experiencing.
For the moment, the federal government is doing what it's doing. So you would imagine now that state levels and cities, this is a very live discussion about what can we local governments, city and state governments, do in whatever the interim is to deal with some of these massive issues. And as you're saying, I mean, they can't do everything, but they have to do something. I mean, what are those things that cities can do, especially cities that are not as well resourced as New York, that don't have these huge health and hospital corporations where resources are scarce?
Primary care is really important, and if you could do a lot of preventive care, you will avoid much more expensive interventions in the future. So that's really, you know, that access to preventive care is really important.
Yeah.
There's also a problem with addressing one aspect of healthcare without addressing the others. I mean, you know, not addressing the cost of pharmaceuticals and, you know, swirling out of control in terms of the pricing of pharmaceuticals or other aspects of healthcare. Healthcare is an ocean. It's not a spring. And so all these rivers pour into that ocean that seems to be out of control. And so addressing one aspect of it, third-party payers, pharmaceutical products, you know, physicians' fees, availability of primary and preventive care is all part of a large economic formula that is ill-addressed if we only take one thing and insist on talking about nothing else.
Right.
So this whole debate about the Affordable Care Act is addressing a perspective in health and healthcare that is, if addressed alone, obviously will never answer the question. But I mean, just to give you an example, the example of Medicare. You know, in the 60s, when Medicare legislation appeared, you know, there were almost 500 reforms of the law within a year or two. So health and healthcare and the human reaction and behaviors to health law are unpredictable. The first thing that appeared was that, in fact, elderly people were not going into bankruptcy because of health reasons, even before we saw any changes in their health. And furthermore, by applying Medicare, looking at how people used it, it was obvious that the law needed more and more and more reforms until it arrived at a point where it was stable. The same can be said about the Affordable Care Act or any other legislation.
Right.
I mean, I think the other thing is thinking about, and this is getting back to what you were talking about before, thinking about the social determinants of health also and addressing all of the things that feed into a person's health. So really not just focusing on coverage or even not just necessarily focusing on health outcomes, but focusing on the community, focusing on housing, like all of those things that really feed into a person's health.
You did mention in the beginning that although healthcare did have the worst disparities, it actually, in the New York City context, the measures that ISLG looks at actually did improve over the last couple of years. Where was that improvement? Because that is at least some good news.
Right. And that was access to healthcare, that was uninsured rates. We saw much fewer disparities there, and going to a primary care physician, which is not surprisingly, those are two related. But we saw huge improvements in those two measures. And I would have to think that a lot of that has to do with the Affordable Care Act and all of that legislation, which that was our one really bright spot in healthcare.
Right. Right. Lilian, I'm going to ask you this because you have a lot of experience this. I mean, Andrew's piece, part of that piece was about access to health care and how complicated the system of Medicaid is in terms of getting access and getting services. You ran a lot of the agencies that intersect with this. What is it that residents can do or learn to at least limit the difficulty of getting access to services through Medicaid?
So, you know, by and large, I think things have gotten considerably better than they used to be 10, 15 years ago. I think, like any eligibility for any kind of an entitlement is a difficult thing to achieve sometimes. It shouldn't be, but it is. Mm-hmm. I think hospitals have gotten better at negotiating the eligibility process. And I think the more we have people who know how to do eligibility at the local level, at the hospital level, we're much better off. I think people also have to, a lot of people don't apply for Medicaid when they should simply because they think they're not eligible. And I think we have to do a lot more about educating people about their eligibility rights. Now, that all may change. So, it's problematic as can be. But the reality is that many, many people are eligible that are not accessing it. And you can't wait until you get hospitalized or you have a problem to then sort out the eligibility issues. I think that's probably the most important thing to remember. And Medicaid, HRA, Medicaid is administered by the HRA, the Human Resources Administration. They have to do more at educating at the hospitals at the local level.
Right. So this is at least this part of the discussion is a sort of HRA city government issue that sounds like has gotten better, but still has a ways to go.
Yes, I mean, the state has taken over a lot of the eligibility process in the city. So I think part of why we're experiencing some delays, maybe some of that hiccups of the change in how to do eligibility.
I see. Well, great. So that's all we have time for. Thank you again for watching The Wonk. I'm Michael Jacobson, and we will be back soon with more in-depth policy discussions about our city. See you next time.